Perfect. So we are going to get started here with our session today, Beyond the Classroom, helping students master clinical rotations. So thank you so much for joining us today. As a reminder, this webinar will be recorded and everyone who registered will get a link to the recording after the session today. Our key speaker today is Dr. Delia Chiaramonte, who I will introduce in a minute. She'll be in conversation with Bob Boehringer, who I'll also introduce, but I just have a few pieces of housekeeping first. All right. Before we get started, everyone's automatically muted, so don't worry about that at all. The chat is open. Please use the chat if you have questions for our speakers today, or if you have any technical issues. Me and my coworker, Erin from McGraw Hill, will both be peeking at the chat to help you out. The webinar is being recorded. I've already mentioned that today. And then again, yes, tech issues, please let us know. And with that, we're ready to get started. All right. So who do we have here in front of us today? Today, we are so lucky to be joined by Dr. Delia Chiaramonte. Dr. Delia is a physician and medical educator who is a board certified in family medicine and palliative medicine. She's a part-time assistant professor at Johns Hopkins University School of Medicine, where she teaches in the Palliative Medicine Fellowship, and is also an adjunct assistant professor at the University of Maryland, where she teaches multiple asynchronous courses for medical learners. She's an executive medical editor for McGraw Hill. Dr. Chiaramonte's prior positions include Division Chief of Palliative Medicine at Greater Baltimore Medical Center and Director of Education and Associate Director of the University of Maryland School of Medicine Center for Integrative Medicine, where she taught medical students for a decade. She has also served as residency faculty for a family medicine residency. Dr. Chiaramonte has been voted a top doctor by her physician peers and has published multiple textbook chapters in the fields of pain management and palliative medicine. So thank you, Dr. Chiaramonte, for joining us today. I'm going to hand it over to Bob to get the conversation going. Bob Boehringer from McGraw Hill is the Director of Medical Test Prep here at McGraw Hill, which includes the case files collection, teaching cases, first aid, and more. All right, thank you.
Thank you, Kaylin, and good morning for some, good afternoon. Very happy to be here today to talk about this really important topic about transitioning from preclinical to clinical. I have the great pleasure of working almost daily with medical students because my philosophy in product development is that it really doesn't, products really don't serve a purpose unless they're serving some sort of need or addressing some sort of pain point for customers. And that being said, almost everything I do is run by either initiated or run by students or run by them to make sure that we're on the right track. To that end, a lot of students, when we talk about different pain points, mention this whole idea of struggling when it comes to moving from didactic into clinical. Some schools prepare them better than others, but making the leap from just learning to application can be challenging. So with that said, I think that's a good place to start with Dr. Chiaramonte. I'd like to hear your thoughts on why this struggle is so real.
Thanks, Bob. I appreciate it. And I'm really glad to talk about this topic, which I love dearly. So I think big picture, part of why it's so hard is that it is a completely new world where students feel out of control and like a stranger in a strange land. And they're used to, these are good students, right? They're used to knowing exactly what's happening and how to succeed. And all of a sudden they get dropped into this completely different culture and they're terrified. So they're scared of hurting somebody. They're scared, though, probably even more of being humiliated on rounds, because there's a little bit of that in medical culture. And I think mostly they're scared of just not doing a good job. These are people who have done a good job since they were in first grade. And now they don't know how to do a good job. And it's out of control. It's new. It's not clear. It's not like if you get this score on this thing, everyone will say you're great. So mostly the feeling is fear. I don't know what this is. I don't know how to do it. I don't know how to succeed. And that makes them very distressed because they are people who are used to succeeding.
And would you say that based on what you've heard in the market that this is something recognized and supported by the majority of schools?
Yeah, it's totally recognized because all of us who are physicians have been there. But there is a little bit, certainly previously, but even still, even in talking to medical students recently, there's a little bit of a feeling of, well, we did it, so you'll be fine. Like, just kind of suck it up, you'll be fine. But I think more and more with this generation, they're asking not to be miserable. And they're saying, well, if you know that this is a problem, then help us feel better. We don't accept so much, sure, I'll just be miserable and scared, then that's fine. They feel more like, why should I have to be miserable and scared? And if you
Yeah.
know it's a problem, why can't you help me make it better?
Yeah. And so the mental health piece is a big piece too. But is
Yeah.
there anything on top of that related to maybe some of the either the way they've learned or any sort of content gaps that you've heard that they worry about as well?
Sure. So even let's just assume they were in a traditional classroom or for a moment where they had 2 years of didactics and 2 years of clinical. I know that's often not the case anymore, although sometimes it still is. There is a really significant difference between learning something in your frontal lobe as a fact and then implementing it in the clinical scenario. So part of how they learn, of course, as we all know, is that they pretend to be a doctor. So they'll be given a few patients and they'll be sent in to go take a history from these patients. And the thing that is markedly different, that is still true, was so true for me, is still true, is people don't come with a placard, I have lupus, right? They don't come saying they only have the symptoms that match their disease. So when you learn about a disease, you learn about lupus, you learn about the few things you're going to look for. But when you see an actual human, maybe they have those things, plus their head hurts, plus their foot hurts, plus they can't sleep. And so they give you this much bigger chunk of information, and you have to pull out from that the thing that is clinically relevant. And that's hard. That's hard even for experienced clinicians. But you don't really get to practice that until you're in the room with actual people.
Yeah, that makes a lot of sense. Should we it looks like we're getting ready to pull up um the first chat question. And that is, what do your students struggle with or worry about most when they transition from didactic learning to clinical rotations? Like to hear from the audience on that.
In the chat, please.
In the chat, yes. Thank you for.
Absolutely. And as people are writing that down, one of the things that I think is important to remember is that in the clinical scenario, students will get negative feedback because they don't know exactly how to prepare a case, how to present a case, and they'll mess up because this is a completely new skill set. And these are often people who are not used to getting negative feedback, right? They got into medical school, which is hard to do. They're used to being the top of everything and best at everything. And all of a sudden, not only are they the lowest on the totem pole in the hospital setting, but also they'll probably mess up and someone's going to tell them that they messed up. And they may even get that feedback in a group. They may try to present a case on rounds and be told, well, what about this? And you said that wrong. And what about that? And all of a sudden they feel less than and ashamed. And they are often absolutely not used to that experience.
Yeah, there's some really good responses here. They kind of range from safety to forgetting the skills they've already learned. And I think there's a lot under the theme of, they want to make sure they're prepared because answering presenting the wrong answer certainly has its consequences, right?
Right. And the truth is, and this is part of how we can help them, is by giving them understanding of the culture. It's actually fine to say the wrong answer. Someone will say, no, that's wrong. But as teachers, it's fine to say the wrong answer. What the teacher really wants to see is that they've tried, that they are practicing their skills. So they practice presenting a case, that they looked up information about their patients overnight. So the student is so worried about getting the wrong answer the teacher, the clinical teacher, doesn't care if you get the wrong answer. As what they care about is that you're trying to learn, that you're doing your best, that you're showing up and you're making an effort. But students often don't see it that way. They feel like if they present and the attending says, no, that's wrong, then their face gets red and they're ashamed and they feel like they failed. Whereas the attending may feel like, hey, you did a great presentation. I know why you said you thought it was that, but actually it's this other thing. The attending may think they did a great job, but the student may feel like they did a terrible job.
Yeah, and I feel like we're hearing a lot about and this is the same type of thing that I've heard from students as well. But there is a great deal of anxiety because there's a lot at stake when it comes to their evaluations, and if their fear of answering the wrong way, they probably have in the back of their minds that it's going to impact their evaluation. Would that be an accurate statement?
It would be accurate that they think that. And I see that someone said an irrational fear of the wrong answer. But in terms of will it actually impact their evaluation negatively? No. If they've shown up, they've practiced presenting, they presented a case, and they explain why they think this person is having a heart attack, even if the person really is having reflux, but they can say, well, they had substernal chest pain and they said, maybe it went to their jaw. Yeah, their EKG was normal, but I thought maybe because of their father had it, so I thought maybe it really was that. The attending will say, well, good for you. I see why you thought that. That's wrong, but I see why you thought that. And you're thinking like a doctor, which is what I want you to be doing. So it's not that the wrong answer is the problem. If someone just shows up and they look like they don't care and they do a terrible job presenting and they're late to rounds and they didn't pre-round on their patients and they get the wrong answer, they may get a negative evaluation, but it's not about the answer. It's about how they showed up to this process.
Well, given our audience and since a lot of the people in the audience right now are thinking, this is all stuff we're directly experiencing, and hopefully our discussion today is going to focus on ways to address the problems. What would you say would be the best thing faculty can do to help support students as they go through this?
Yeah, it's a great question. I think some of it has to do with culture. We'll talk about that. And some of it has to do with actual skills. So let's talk about culture first. The first thing that I think is important for faculty to help students is to normalize that this experience is difficult and it's not just you, because students tend to have imposter syndrome and feel like everybody else is comfortable and knows what's going on. It's just me. And of course, that's not true. And even though they may learn about imposter syndrome in some lecture, they don't really internalize it until they literally think, oh my gosh, I'm so stupid. I'm so ashamed. They think I'm terrible. Everyone else looks great. So just telling them, you feel this way, you will feel this way. It's part of the culture of this experience. And pretty much everyone else feels this way too. The other thing that I think is important to tell people that I did not know till I was an attending is that here's how it works. Overnight, if you're on call overnight as an attending, you get a call from the resident. Hi, I'm admitting this person who has Addison's disease, something maybe I haven't seen that much of. I read about it overnight. So when I'm asking questions in the morning on rounds of the students, I read about it last night. And so that you as a student can feel like, oh my God, everyone knows everything and I'll never know anything. So even letting them know, hey, your resident read about it overnight, your attending read about it overnight. So what can you do to feel a little more comfortable on rounds? Be sure you read about your patients overnight. So if you know you pre-round, you're going to get a patient with a condition, go read about it so that you feel more comfortable when you present on rounds. The other thing I think is important is to let them know that they will get negative feedback, and that's fine. Negative feedback doesn't mean they did something wrong. The other thing I didn't know until I was an attending is that when you're teaching someone, we almost always ask questions until they get something wrong, which makes the student feel like, oh my God, I always get things wrong on rounds, right? Because you're a clinical teacher. If we only ask you stuff you already know, we didn't teach you anything. So we will continue to ask you until you get something wrong. And so rather than the student processing that as, oh my gosh, every day on rounds, I get something wrong, tell them, yeah, this is a learning experience. They're going to do that until you get something wrong because they want to teach you. It's okay. It's okay to get things wrong. show up like you care, like you tried, like you want to learn, that's how you get a good grade on a rotation. It's not about what fact you knew.
Yeah, that's really good insight. And that's a great way to sort of look at the emotional side of this. And you sort of touched on resources, because I'm sure there's a part of this that involves them questioning their knowledge. So
For sure.
on the knowledge side, are there, what types of resources, and you don't have to mention specifics, or you can, but what types of resources would it be best to point them towards to give them more confidence from a knowledge base?
Sure. It what the skill that they need that's different than just learning for tests is they need to be able to think in terms of cases, in terms of human beings who are basically cases. So practicing with cases in general is very important because it changes the way you think. Instead of recognizing a fact, you see a constellation of symptoms and start creating a differential diagnosis. So that skill of practicing making differential diagnoses is really important. And they can do it, of course, for their own patients. They could even think about it on rounds when other people are presenting. They can be thinking in their mind, what would the differential diagnosis be? And so doing cases of various kinds, question-based cases or more extensive progressive cases, helps them take it from lupus has a malar rash to this person presents with this constellation of symptoms. What should I start to think about? How would I know? So here's my big differential now. They got this test and that test, and I did this physical exam. I whittled it down to 3 things on my differential. What do I need to do to get it down to 1? So thinking in that way, practicing doing cases so you learn to think in that way, helps you kind of think on your feet during rounds, because those are the kinds of questions that you'll get asked on rounds. Okay, you presented to your patient, this is what they have, what do you think we should do next? And that you can't pull that from your memory bank, you have to pull that from your thinking bank.
Right. I feel like you set me up there, because as a person who oversees the case files products, I do hear a lot about how students use those to really, and it's more to sort of refine their clinical decision-making skills. So, along those lines, I think, we hear that a lot, and that is primarily how and why those are used. So it looks like we are ready for the poll question. So we're going to put a poll up. How would you describe the mental health of your students now compared to 5 years ago? So feel free to submit your answers, and let's take a look at what everyone has to say.
And while people are doing that, I think another thing that's important to mention is that preparation really is key. So if students have a patient that they're seeing, they should go read about that patient. They should make a differential for that patient. They should practice presenting a case. I think a lot of students don't do this. They gather all their information, and then the first time they're practicing cases is when they're on rounds, when they're terrified. In front of a mirror, really just practice presenting your case over and over and over again, because it's only that way that you get really comfortable with presentation. And those kinds of things are what make attendings feel like, wow, that's a really good student. If you can come and say, this is a 45-year-old man with this thing, that makes them feel like a good student. Oh, how interesting. What do you think, Bob?
So you have any thoughts about that?
Well, I'm not surprised.
Yes, right. I can't say I am either.
I'm not surprised at all. Of course, we can pontificate for hours about why this might be, but I do think it's really important for us to recognize this, that look how many people, what percentage of these people are somewhat or much worse now. That is stunning, really. Not stunning, but stunning. Look at that stress. And the thing that's changed perhaps in society is that I don't think that's okay. And I think more and more people are feeling like that's not okay. And I personally feel like this is something that medical schools need to actively address, instead of just feeling like, oh yeah, well, they're stressed, because there are not an insignificant number of medical student suicides, resident suicides, attending suicides. There recently was another one. It's heartbreaking, and it is unnecessary, right? These are, for the most part, on some level at least, privileged people who are so hopeless that they don't see a way out, even though they're smart, they have some amount of connections, they could reach out for help, and still a really unacceptable number of people don't feel like there's a way out. And so that's why I think this topic is so important, because there's no question that the specifics, learn to present a case, learn to think clinically, learn to make a differential, these are crucial, no question. But managing what's happening inside your head and having skills to reduce your own distress and having a community where you're learning that feels like you can go for help without being stigmatized is crucial and is actually life-saving. So it breaks my heart to see that, but also I'm not surprised.
Yep. So we've got a really good question from one of our attendees. Is this being associated with COVID? Is there a reason why you think students are now more stressed?
Well, there's no question that COVID was a global trauma and that the level of anxiety in general and distress is elevated. There's no question in my mind. Medical students have been stressed for a very long time, but this question was specifically about why is it worse now than before. I do think that I can say this because I have 2 young adult children. There is something in their peer group in general, separate even from medical school, about there's school shootings, there's climate change, there's a pandemic. Like they have a feeling of lack of safety in the universe that I feel like is worse. And so when you're then put in a very high stress situation like medical students with, also because of the internet, they know people who don't match, right? On match day, you can look on Twitter and there's person after person after person. I didn't match, I didn't match, I didn't match. Oh my God, oh my God, oh my God. So there's this heightened level of, oh my God, what if I mess up on rounds today? And that means I get a pass instead of a high pass or honors. And that means I don't get a residency. And now I have $400,000 in school debt. My life is over. So they're already catastrophizing like to their bankruptcy, and they haven't even presented yet on rounds. So I think all of the things that they've lived through, plus a lack of skills to manage their own catastrophizing, is why they've ended up in this place.
So along those lines, in terms of matching, do you think that the step 1 moving to pass fail do you think that's made the clinical piece much more high stakes for some students?
I do think it has made the clinical piece more high stakes because I used to be a residency attending. And so we would interview a ton of students, and we together collectively would have these hours and hours of meetings to evaluate every student and talk about them and get information about them from all the people who talk to them and rank them. And so when we have more, when faculty have less objective information, they're going to use what they have because they can't take all the people who apply. They have to rank them somehow. So I know there've been some challenges with step 1 going pass fail, and the fail rate has gone up a bit. And I think that's just sort of a behavioral thing that'll probably ease itself out. Ultimately, I'm not saying it's a bad thing, because we do want people to be judged on their clinical behaviors, because that's the skill they're supposed to be learning when they become doctors. But I do think that it makes it a little bit more high stakes. It may not be a bad thing, but I do think it does.
Yeah. Well, we're going to take that a step further because we got a really great question from the audience. How do we care for mental health, but also give critical, constructive feedback?
Yeah, what a great question. What a great question. I think part of how we do that is by teaching people to receive constructive feedback. And you can't do that only after they're getting the constructive feedback. Now, I'm going to say something that does not come from me being a sociologist, but I did raise children. And I think that there is a little bit of like, everybody gets a trophy and you're also wonderful and special. And people are not used to getting a ton of constructive or negative feedback. So I think talking about that, I think having sessions in the medical school periodically about, let's talk about negative feedback. And let's role play a little bit, some negative feedback. How do you feel? How do you feel? You turned red, you feel ashamed. Hey, everybody else, do you think he did a terrible job? And they'll say, no, he just, he missed that thing. And so they gave feedback. So I think they don't have a lot of practice before they get to medical school. We can't fix that, but we could give them some practice. I think it's important to talk about it. It's hard, it makes you feel bad, but the truth is it's really important, and it's a skill to receive constructive feedback. We're going to practice that skill just like we practice doing pelvic exams. You know, we're going to practice the skills you need. This is one of the skills that you need.
Here's another really good one. I feel like the participants are putting our questions to shame.
Awesome.
Because this is another really thought-provoking one. Should we challenge the notion that competitiveness is the key requirement for medical school? Does this not just lead to perfectionism? Do patients need perfectionist doctors?
I love that question. No, patients do not need perfectionist doctors. So I was a French major because I figured if I didn't get into medical school, I wanted to have some teaching in liberal arts just in case my career was going to go in a different way. So I am biased. I think that being a well-rounded person and an empathetic, caring, thoughtful, careful, smart, hardworking person is important, but I do not think that being the person who did best on organic chemistry makes you a better doctor. So that is a whole culture shift that I would encourage. And it's actually part of why I think having these kinds of conversations and having conversations around you as a whole person in the medical school, you student as a whole person, that this is not like, oh, some soft stuff that we'll throw in at the end of the semester, but that this is crucial emotional intelligence for you to take care of your own well-being, and also so that you can understand the patient's well-being. Because the truth is, if we create automatons who are great at spitting out information but don't have good emotional intelligence, can't talk to people, aren't good listeners, don't have access to their empathy, they're generally not great doctors either. If they ever leave the operating room or the pathology suite, there are key skills that they need. But I think part of the problem in medical education and assessment is that those things are not tested. And so students prioritize what is tested, and then they end up being better at the things that are tested.
Yeah, really, the great questions. And this really led to a great conversation. But I'm going to flip over again because we want to make sure this is a good combination of sharing of thoughts as well as suggesting potential solutions.
Yep.
And I feel like there were a lot of great pearls that have been included in some of your responses about bringing this. How does a program and or individual faculty bring this into a program, bring this into a class? The one idea that you said that really sticks in my mind, which I absolutely love, is this whole notion of showing them, demonstrating, how one might take negative feedback and learn and grow from that. But can you think of anything that you haven't covered, ways that you could incorporate information and or techniques into a class or program that might set students up for success?
Sure. I think that practicing cases in a group and struggling, making them intentionally challenging, I think is important, because you want students to struggle a little bit. You don't want to just give them, here, did you memorize all that stuff? Here's this. Or even a simple case where they were like, oh, the person, has a family history of a rheumatologic disease and a malar rash, they have lupus. But ones that are more like human beings, ones where there's a lot of distracting information, ones where in the beginning, your differential diagnosis is ridiculously large. So sometimes cases can be so tight that they don't give the student the opportunity to practice not having any clue what to do next. And also encouraging students, making it normalized to struggle. So struggle out loud. Tell us what you're thinking out loud, as opposed to focusing on, did you get the answer? I think having people practice the process out loud with their leader as a group and struggle on purpose is really important, and is much more important than did they ultimately get to the answer.
That's really interesting. Yeah. I think too that you're making me think that one of the key, and we hear this a lot too from faculty, is that cases can be a really powerful tool, but on the flip side of that, it sounds like there really is a need for people, whether or not they've prepared or been thrown into an assignment. The need to really be good at to sharpen your facilitator skills, because I guess that really is the make or break there, right? To sort of guide, shepherd students through this journey. Can you say a little bit about that?
Yeah, that's such a great point. So the way medical education works, as we all know, is sometimes, often, the educators are not people who are trained in education necessarily. They're academic people who may have a clinical practice, maybe, who may also be running this course. They may not have gotten a lot of experience in educational theory and facilitating groups. I would say one great intervention that medical schools could do would be to send their faculty who are doing this kind of mentoring to training, and even have faculty mentoring. Let the faculty get together, practice mentoring with each other so that they become really strong, because that will trickle down. And then that makes it clearer that the concept that you're looking for is the struggle. So I think telling students, if you can, these cases are not graded, or you're graded on your participation and not on your answer. I think making faculty trained to be really good facilitators, and then facilitate in a way that allows people to go outside their comfort zone and make mistakes and say things that might be wrong, and not worry that that means now they got a worse grade. Because if they think I'm getting graded on what I say that's correct, they will not take a risk. And if they don't take a risk, they don't get to practice, and then they're thrown into the clinical scenario where they kind of have to take a risk. They don't know how, they get negative feedback, and then they're crushed. And so we can change that whole dynamic. But I love what you said, because I do think it starts with mentoring and training faculty and facilitation. And I also am very pro flipped classroom. So using tools like video education, we have some, other companies have some too, video education of the info, then come to class with these trained faculty facilitators and practice not just the medicine, but the idea of working through a case, of allowing yourself to take a risk, of allowing yourself to get feedback, of working in a group in a way that is not for your own grade, but for figuring out the answer so the patient can be well. I think that whole pathway could make students who are more used to thinking this way and are more willing to take constructive feedback because they see the purpose of it.
Yeah. So one of my favorite types of questions just popped up, because I really like it when people in the audience take note of everything that's being said, but also there's realists in the group, and this person says all of this takes time that busy clinicians don't have the luxury of. Any tips on how faculty can assess students that don't take too much time?
Yeah, that's a great question too. I do think one of the challenges in assessing students is that the faculty are just living their life and trying to get their patients seen and are being asked to assess the student. I've always found this to be a significant concern. I think that there should be maybe a paper that the student carries around that just says, write down one piece of information about the student after you worked with them for 2 hours, for example, because I'll tell you what happens in real life, and this has happened to me just recently. You get a stack. Here, you've seen these 12 students in the past 6 months. Please fill out these papers. And I don't even remember these students from months ago now, but these are really high stakes reviews, but I literally don't remember the student. And so it would be much better to say, as you spend time with the student, please just write down one sentence about what was a thing I did well, what was a thing that I could improve upon, for example. So making it in time, I think, would be huge. Also, training students how they can both learn and be of service, I think, is important, because no one teaches them that. So some students show up and they're really motivated. Some students show up and they just kind of like slump in the corner, and you feel like, as a faculty member, am I supposed to draw them out? What am I supposed to do here? So I think teaching students how to be in control of their own education, and maybe even come to the faculty and say, okay, we're on outpatient gynecology today. One thing I would really like to learn today is how to do a pap smear well. Would that be something we could work on? Then the faculty member also feels successful. Like, all right, if I teach them how to do a pap smear, I've done a good job. because faculty are people too, and they just feel like everybody wants something from me all the time. Did I do a good job with the student? Probably not. I don't know. And then they feel badly. But if they had a task, teach me a pap smear, and they did it, they would feel good. So I think teaching students to be in control of their own education in general, and then think about one or two things, tell your faculty member that day, I would love to learn this if it's possible, and then everybody feels better.
Yeah, good. So we're going to post one more chat question. And it is going to be related to learning gaps. What learning gaps do your students report most when in a clinical setting? And after this, we'll open it up to general Q&A. We want to make sure that we are respectful of your time and keep things on schedule. So hopefully we'll get some good responses that will provoke some additional questions.
I would love for schools to have at least a week seminar or something, if they can squeeze it into the curriculum, for students about how to take control of your own learning in the clinical context. No one ever taught me that. I've never talked to students who use that language, but that would be a pretty easy thing to do. And I think it would make a difference.
And one thing that we seem to hear a lot about is resources that help students decipher information more quickly and typically reach differential diagnosis more quickly. So is the whole notion of pattern recognition, does that help expedite things in the clinical setting?
Yes and no. So ideally, yes, you learn pattern recognition, but if you're not careful and you rely only on patterns, you can get to this problem, which is called premature closure, where you see like, oh, a 55-year-old guy's got chest pain, he's having a heart attack. And maybe he's not, maybe he's having a ruptured aneurysm. So yes, we think in patterns, but so for new learners, yes, learn patterns first. But for more advanced learners, learn the pattern, but also look at all the other clues and make sure that you're not prematurely closing your mind to some other possibility.
Yeah. So we've got answers. I'm just going to read them and feel free to comment on them. Heart murmurs and MSK exam, which probably isn't surprising, right?
Yeah, physical exam. I've been teaching for a long time, and physical exam skills seem to have declined, which is concerning. And I don't know if that's because everybody gets a scan. Maybe, there are times when, it's been a while now, but when I would work in the hospital and people would get a CT scan before they were even seen by a doctor. So I think we do over rely a little bit on technology, which is not perfect. It's not perfect. So assuming that I got a CT scan and so now I don't have to examine the patient because I know what they have is not true. So I do think that prioritizing practice in physical exam is really important. And so you might say, in that example, if you're going to rotate through cardiology, you might say, I'd really like to learn about murmurs today. So if you find any murmurs, would you mind if you let me have a listen? That would be a way to take control of your own education. I need more experience with heart murmurs, maybe even while I'm on medicine for the month, but I really want to learn heart murmurs. Let me ask cardiology, can I rotate with you for a day? Even though I'm on medicine, make sure my medicine attending says that's okay. But if you go in there and say, I'd really like to learn heart murmurs, and the cardiologist said I could spend a day with him so that I could learn heart murmurs, would that be okay? They're going to say, yeah, sure, go ahead and do that. That's taking charge of your own education, but no one's going to do that for you.
Yeah. So this one, the empathy toy, is a great tool to practice advocating for your own education and also how to approach teaching.
I don't know what that is. The empathy toy? Is that a term that that you can teach me?
I don't.
Well, whoever wrote it, Christine, if you could teach us about that, I would love to learn. It sounds like something I would love, but I don't know what it is.
This is one that I think is so relevant. They don't know how to put things together. They were trained and assessed in a true, false, or multiple choice manner. They don't know how to attach the diagnosis and treatment because patient care is not cut and dry.
Exactly. So that's the exact reason, like we said before, to think about a flipped classroom where maybe they're watching videos of the facts beforehand, and then they're working, struggling through cases during class, and then practicing with more cases so that they do learn that concept of taking what's in your mind and putting it together with patterns of disease, as you mentioned, and also real human beings, and
Yeah.
practicing that. And I also do think that it's a great tool if you have the opportunity in your curriculum to bring in actual patients and let them hear, what is that like? How did you present? How did you feel? What was happening for you before you went to the doctor? So that they really can start to understand that when they talk to an actual person, they're not going to list the 5 classic things that are in the textbook. That's not how they're going to talk about what's happening for them.
Yeah.
More experience they have with that, the less horrific it will be when they first go into a room and interview a patient.
Yeah. One of our attendees says, amazingly, many students have issues with medical terminology.
Oh my goodness. I'm not sure even how to respond to that. They shouldn't have that. I don't know why they have that. I don't know why that is. I don't know why that is. What do you think, Bob?
I don't know. I mean,
Surprising.
yeah, that does surprise me as well. But I have heard too from some of the directors of clerkships that and maybe these go hand in hand, that sometimes the students don't come in with basic knowledge of professionalism. So
Yes.
maybe some of these basic assumed either banks of knowledge or skills they're maybe not focusing on as much. I don't know.
Yeah, well, you know what just struck me too, in addition to that, when you were talking, is maybe faculty are not giving feedback because everybody's afraid to give this generation, quote, negative or constructive feedback. So yet another reason to practice getting feedback. So as a busy faculty member, if a student says something that is wrong, medically wrong, I could ignore it or I could say something. But if I'm afraid that they're going to start crying, maybe I'm just like, oh, I just won't say it. So let's teach everybody, right? Let's hold everybody to high standards of professionalism and owning your own learning, and teach the teachers how to teach the students, which includes kind ways to give constructive feedback. Because if they say something that is medically incorrect and from a terminology point of view and you let it go, they're going to say it again. And the
Yeah.
next person may not correct them. And that's terrible for the student. That's not good education. So we need to be willing to take a risk and hurt somebody's feelings. We'll say it in a nice way. Hopefully in their school, they've practiced getting constructive feedback so that when they get some, they don't fall apart. I think that's just an important part of being an adult learner.
Yeah, this supports that, and it's very well articulated. Lack of expectations, situational awareness is lacking, and that seems so simple, but I'm sure many schools either don't have time. There's not a coordination between the two pieces, but yeah, that seems like it really would make a difference.
Yeah, there is also a cultural thing. I don't know what we can do about this one, but there is a cultural thing that's changed since I was in medical school, which is there's more caution about who can do what, who can touch what patient. And I think medical students are a little more marginalized in the clinical learning encounter than they were when I was a student. We used to be able to do things, and now they're like, oh my God, you're a student, don't touch anyone, don't do anything, don't hurt anything. So if the teacher isn't careful, they can just park the student in the corner and they may zone out, and the teacher may just be seeing their patients, and that's unfortunate. That is unfortunate.
Yeah.
The other thing that would be nice, this is a cultural thing that we can't fix, but schools in theory, hospitals in theory could fix it, is to give clinical teachers a little break from their clinical responsibilities so that they can pay attention to teaching. That's often not done, and the doctor's just trying to get through their day, and so the medical student is a low priority. If there is some way that we could relieve them of a half a day of patient care so they have more time to do teaching, that really would be a positive development.
Yeah, and this sort of supports everything we've been saying all along, because they always, this person is saying, they always say it's knowledge, but it's more about retrieval of the knowledge and then using that knowledge in context.
Right. And I do think that teaching clinical teachers is important too. So not just faculty facilitators in terms of cases, but also people that are taking students into their office. Offer them some some teaching training, have them come and give them lunch. Many people want to do a great job. I know people are very busy. I've been that person, but also if there was a free thing and you got a half day off and they gave you lunch and they said, come learn to be a great clinical teacher, I would have gone. A lot of my peers would go. And so people don't do what they don't know how to do. So if you're an internal medicine doctor and they say, here's a student, and no one ever really taught you how to teach them in the office, you may not know how to do it and you may not do a great job. But there are skills that you can have and learn about how to be a better teacher for that student. I think
So the
know.
person who mentioned empathy toys was kind enough to send a link. So
thank you. What is
we can learn more about that. And that's for anyone interested, that's in the chat.
Thank you for that. I'll check it out too and definitely learn from you. I appreciate that. I think empathy in general, empathy is a key skill. So what skills do they need in the clinical encounter that they don't need so much when they're just doing tests? Empathy, 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 humility, right? Which goes along with being able to take constructive feedback. So I was the top of the class forever and I know everything and I get all the answers right. And then all of a sudden I'm on rounds and someone says, well, actually you didn't do a great job. You should have done this other thing. And, humility would say, whew, like that made my cheeks red, but thank you for telling me that. I do want to learn to be a great doctor. Like, okay, I will work on that better. Whereas if someone comes at it more from, I'm going to do the very best thing or arrogance, they may be kind of crushed by that and they may get defensive and they may block out any learning that's about to come their way. So empathy, humility are really important. They got to learn how to present a case. They have to have some stamina because on some rotations, they may be up all night. They may not be used to that. If some of them have been learning in their pajamas for their, the past 5 years, this may be challenging to work a 15, 16-hour day. So that's new too. And the other thing I think is a skill that they really need is to learn to ask for help. There's a great culture in medicine of not asking for help. And I think top students sometimes are not used to asking for help. They were the people that right. Other people came to for help. So management of their own distress and normalizing if you feel you're not sure what to do, you want to learn something, you're stressed out, whatever it is you need help with, that it's normal and appropriate and good, and here's the resources, I think is very important. And the other thing I think around that's very important is not to make it like, oh, well, you could always go to the therapists who help people when they're really a mess. That's a wonderful thing. And yes, we should screen students for depression and have therapy available, but that shouldn't be the threshold for asking for help. You should be asking for help in managing your stress every day, all the time, even if you're not falling apart. It shouldn't be like, I'll hang on by my fingernails till I fall apart, then I'll go to a therapist. It should be like part of being a human is checking in with my own stress and distress, having my toolbox for managing my own stress, reaching out for help before I'm really in trouble. All of those things are just normal human skills that we should be teaching because they may not show up in med school with those skills.
Well, having been a webinar attendee many times over, I know that they can range in quality. I feel like thanks to you, Dr. Chiaramonte, and the audience for such thought-provoking questions. I feel like, I myself have learned a lot, and I feel like this has been a really meaningful conversation. At this point, we've got about 9 minutes left. I feel like the questions will probably be on the lighter side only because you guys have done such a great job throughout the session submitting questions. But because of that, do you have any final thoughts on anything you'd like to share?
Yeah, I think the last thing I'd like to share is that we can teach students skills to manage their own stress and distress as though this is just a thing people need to learn how to do. So, for example, we can teach them about catastrophizing, which is, oh my God, I did badly today. I'm going to flunk med school. I'm going to be homeless, right? That's catastrophizing. I struggled on rounds today means I struggled on rounds today, not I'm going to be homeless. So teaching them about what is catastrophizing, that we can use tools like, let me rub my hands together, take a deep breath and focus on what's happening right here in the moment. Right here, I'm having a webinar. I see trees outside my window. I hear my dog in the background. Let me just focus on right now. I had a bad presentation on rounds, but that's just right now. So we could teach them that skill. We can teach them to use guided imagery apps, Headspace, Calm, Buddhify. There's a million. Some of them are free, on purpose, not waiting till they're falling apart, but just, hey, this is a stressful time of my life. My nervous system is super ramped up. Let me practice some ways to turn down my sympathetic nervous system and turn up my parasympathetic nervous system, because that's going to help me feel better, sleep better. It's going to help my frontal lobe work better. So just as like life skills, I feel like in medical school is a great place to teach people skills like that.
Okay, well, there's looks like there's just one other question. I mentioned earlier our case files products, but what other education tools are available? And obviously, we'll talk from our specific end to assist faculty in helping students successfully bridge this gap. This transition.
Sure. Cases like we talked about. I think using Boards and Beyond videos, if you have a flipped classroom, or even just to support the knowledge so that you have a little time in the classroom to work on cases and practice making differentials, I think is important. That we have something called Clinical Confidence, which was made specifically to help students with this leap from didactic knowledge to being in the clinic. And it has much more practical stuff like, how do I call a consult? What are these instruments in the operating room called? How do I order blood? How do I figure out the amount of fluids that this baby needs based on its dehydration status and its weight? So I think that is a really helpful product, just to give people an idea of the practical stuff that you might need to know that you're probably not going to have learned from a textbook.
I just want to bring up a couple questions. I think we've addressed them, but I just want to make sure everyone's questions get addressed. What do you think makes an effective teacher during didactic and clinical years?
As separately as two separate things?
Yeah, I would imagine that's how I'm interpreting the question.
Okay. I think this may seem funny, but as a teacher of both things, I think empathy actually is really important. And what I mean by that is get out of your own self and think about, what does your learner need? So in medical school, I have attended many lectures by faculty that were all about their own stuff that they found interesting, or their research, when really what I wanted to know at that time is, yeah, but what do I need to know to pass boards? So think about the learner and what they need, I think is really important, and not just get up there to say like, look how smart I am, look how many things I know. And there are a lot of teachers who approach it that way, as opposed to, what does that learner need? Because of different levels, they need different things. And I think also in the clinical encounter, if you can even ask the student, hey, we have a busy clinic day today, and I wish I could spend a ton of time, taking you aside teaching you. I probably can't, but what are one or two things that you really want to get out of this session with me? And I'll try to make sure that we hit those things.
Yeah. And then an earlier question too, do you think that the mental health of students is somewhat worse now related to faculty working from home and not in person?
That's a great question. This of course is the world according to Delia, it's my opinion, but I would say yes. I think that human connection is part of what makes hard things easier. And I think it is much easier to just call a faculty member over and say, hey, can I just ask you a question? Like, I haven't been sleeping well. And what do you think I should do about that? Whereas I'm probably not going to make a Zoom meeting to talk to you about that. So
Yeah.
I think you do have the opportunity for just like little nuggets of reach out and help that you don't have if you got to schedule a meeting.
Yeah. I'm going to squeeze a last comment from a participant and then a question. So, and amen to this one. Teach students to take a break from social media. I think we'd all agree
Amen. Please.
on that one. And then our last question is, do you have a suggestion for a mentoring curriculum for faculty?
That's a great question. I don't, but now I want to go look for one. I don't know of a pre-done curriculum. I have done this myself and mentored other faculty. I honestly think if you have fantastic teaching faculty, you probably could have them lead a group. I am going to go look up, though, if there are established curricula. But the truth is, even if there were established curricula, you still have to have somebody great leading it, because this really is human connection. This is empathy kind of teaching. Like, what do you need? Where are you? What do you want to have happen? How do I get you there? So I would start with, if you in your organization have faculty that everyone knows, oh, like, she's a terrific teacher, he's a terrific teacher, see if they would just run a little mentoring group over lunch. See if you can get the school to buy lunch and put it out to everybody. Hey, we're gonna talk about how to be a great faculty mentor, and we'd love to have you show up at this time and you'll have lunch. I think you would start a little internal movement, and in the meantime, we can look up if there are established curricula.
And I'm sure, knowing you, that when you find that, you'll probably reach out to the group and
Absolutely.
send some links. So
Absolutely.
On that note, I want to thank everyone. You all are doing such important and great work in a time that's really, can be very challenging. And we appreciate everything you do. Thank you for your time today. And Dr. Chiaramonte, thank you as well for all the great insights. And as I said before, and the audience for really prompting some very, very great discussion.
And you, Bob, for leading us. This was really fun. Thanks, everybody. I really appreciate it.
Thank you.
All right. Thanks again so much, everyone, for attending today. I said this in the chat as well, but you will get a link to the recording soon, either today or most likely Tuesday. Thank you again, Dr. Chiaramonte, Bob, Aaron, and all the McGraw Hill people who put this together. But especially thank you so much to everyone who attended today. Like I said, you'll hear from us soon. So thank you and have a wonderful weekend.
It would be great to save that chat to see what we can learn from everybody.
For sure.